We will discuss about a case of a chronic otitis media, how to approach the case, what can be the questions asked, and what are ways you should answer the questions, and how can you. So long case, most of the times it will be either a chronic otitis media or a chronic tonsillitis, or it can be a deviated nasal septum. Then again, I will also tell you to consider reading thyroid as a long case, because sometimes if adequate number of chronic otitis media patients are not present at that point of time, we may have to give thyroid as long case, or unsafe type of otitis media as long case. Okay, some nasal polyps. Okay, like atticoantral polyp or ethmoidal polyps as long cases. So we need to have a backup of these cases also. Okay, so we'll discuss one by one in weeks to come, and we can get a clarity of what we are planning. So, like I said, a chronic otitis media patient. Okay. So when we are writing the history of the patient, what are the chief complaints of these patients? Discharge from the ear. Pain, is it always present? Hearing loss. So two main chief complaints. Chief complaints, these two. Try to be in these two only. If sometimes, rarely some patient have some major other complaint, put it. Otherwise, try to write these two as chief complaints. Okay, so one is discharge, and one is hearing loss. Okay. So what will you write in chief complaints? How will you write anything about discharge? Which year? These things are something that we'll discuss in history of present illness. Basically, the duration of the discharge. So this patient is having complaints of discharge from the left or right ear since this many months or this many years. Okay. Second is hearing loss. So hearing loss in the same ear or in both ears. And discharge also for the same thing, like 1 year or both ears since this many days. So usually remember one thing. Most of the times it's the hearing loss and the discharge will be almost of the similar duration. Discharge can start earlier, but don't write that the hearing loss has started earlier than the discharge. It's not something that happens in chronic otitis media. Okay, so hearing loss either starts with the discharge or gradually worsens over time so that the patient understands it. It's not like when we have a 5 decibel hearing loss, we'll be able to appreciate it. No. When we have a significant hearing loss, then only we can appreciate it. So when the patient coming to you with a complaint that I'm having a hearing loss, you're writing the chief complaints, it has to be a significant hearing loss. Okay, so that takes time. Okay, so chronic otitis media, first is discharge, second is hearing loss. Okay. So এটা আমাদের হয়ে গেল। এবার now what do we write in history of present illness? We elaborate the chief complaints, right? In patient's own language. Right? So that is very important. But since we have two chief complaints here, how will we start writing it? Say talk about discharge. So one by one we elaborate both the chief complaints. So first is discharge. What are the points? Onset. What does onset mean? How the discharge started, right? So it can be an acute onset. Patient can tell you, সকালবেলা ঘুম থেকে উঠলাম, কানে থেকে পুঁজ আসছে দেখলাম, অথবা পিকনিকে গেছিলাম, পুকুরে চান করলাম, তারপর থেকে কান থেকে পুঁজ আসছে। ঠিক আছে, acute onset. And another is insidious onset. দেখো অনেকদিন ধরেই হচ্ছে, প্রায় 3 বছর হয়ে গেল, আমরা তো বলতে পারবো না কবে শুরু হয়েছে, বাট হয়ে গেল 3 বছর ধরে যাচ্ছে। So these cases are mostly insidious. These two. Okay. So onset only two things, either acute onset or insidious onset. Second is Duration. Onset is what duration? Always. Don't forget. Duration. So for how many days or months? Okay. So the patient is having an acute onset or insidious. In chronic otitis media, mostly it will be insidious onset. Acute onset discharge in chronic otitis media is unlikely. So the patient is having an insidious onset discharge from the left or right ear or from both ears since this many days. If there is any specific history that the patient can complain, like এটা করতে গিয়ে পর থেকে নোটিস করছি, no, I had to travel and then after that from coming back I'm having this discharge. It's been 3 years now, it's not going down. Okay, something like that. So duration is very simple, no questions about it. So when do we call it a chronic otitis media? When we call it an acute otitis media? How will you differentiate based on duration? Okay. So there is no clear-cut guideline about this, but for all practical purposes, we take 3 months as a cutoff. If the discharge is present for more than 3 months, that's around 12 weeks. It's more likely to be a chronic otitis media than an acute otitis media. Unlikely to be an acute otitis media. Okay? So it's a differentiating point. That's why duration is important. Then what comes next? Amount. Third is amount. Okay. Amount কি হতে পারে? Copious হতে পারে, scanty হতে পারে. Okay. So what is the significance of having a copious discharge or a scanty discharge? So this is not a puzzle. I'm not connecting dots. I need you to understand why. সেটাই তো বললো। See, like I said, কেন হচ্ছে? I want to know why. Because unless and until you're clear about why this is happening, you'll never be able to remember. You'll forget at the time of the exam. Try to understand why. So when we are dealing with a safe type of chronic otitis media, what does that mean? It's a tubotympanic disease. So it's a central perforation most likely in the pars tensa. তাই তো এখানে pars tensa রয়েছে, এটা সেন্ট্রাল পারফোরেশন আছে, ঠিক আছে। So what do you expect when there is a central perforation? Okay, so there is infection going from outside to inside the middle ear. Right? So what is the middle ear lining? Middle ear lining, কি type epithelium? Stratified squamous. Right? It's a columnar epithelium, most of it. So what happens is there are mucus cells. It secretes mucus. So two things to remember here. First is amount of discharge, like you said. Two is nature of the discharge. Okay. So when we are talking of the amount of discharge, so there is inflammation of the entire middle ear. So a lot of mucus cells involved. So there will be a lot of discharge coming out. Okay, so we will have a copious amount of discharge here. Okay, while when we are dealing with a pars flaccida perforation or retraction pocket, so disease is limited to either a retraction pocket like this, or there is localized cholesteatoma or anything like that. So the number of mucoid cells involved is less. So obviously the discharge is less. Pars tensa, we are actually involving the mesotympanum and the hypotympanum, mostly the mesotympanum, the middle part of the middle ear cavity. একটু আগে আসতে পারতিস, সুবিধা হতো। So middle part of the middle ear cavity, the major part of the middle ear cavity is involved. So there is a lot of discharge. But when we are dealing with only the attic or the epitympanum, so the number of mucoid cells are less. So the discharge is also less. সহজ মনে রাখা, it's nothing difficult. ঠিক আছে। Second হচ্ছে nature of discharge. Then again, কি হয় মিডলে আমরা কত রকম ডিসচার্জ পাই মিড ইয়ারে? First is mucoid. Second is serous and mucoid. Will you be able to differentiate from year in the year? It's very difficult. So mainly we deal with three types of discharge: mucoid, mucopurulent, and purulent. So তিনটা main type of discharge we are dealing with. Okay. So when there is involvement of the middle ear and mainly the mesotympanum, so there is a lot of mucoid cells involved. So it will be either mucoid or mucopurulent. Okay, it's unlikely to be frankly purulent because of the involvement of the mucoid cells, mucous cells. Okay, so there will be some mucoid component in it. So most commonly it is either frankly mucoid or mucopurulent. Now these patients with central perforation, they normally tolerate this for months or years because they're not having much problems unless it is infected. So when they get an infection, they will start having discharge. Then they will come to you and they will say, sir, বছরে তো ভালোই থাকি, 2-3 বার করে ঠান্ডা লাগলে এরকম ভাবে জল পড়ে, কটা বাজে রে মা? Either you come on time or don't come, please. So whenever he or she is getting an infection, he is having a discharge. So it's an intermittent discharge. It's not a continuous discharge. So here comes our third point. In nature only, either intermittent or continuous. This is very important. See, when we have a disease here, so it's always an ongoing process. We have a cholesteatoma. It's always eroding the bone, it keeps on growing. So it's always there. It's not related to any infection from outside. Right? Once it has happened, once the cholesteatoma is there, or a granulation tissue is already there, it is already involving the bone, eroding it, going to the mastoid, because mastoid is already there as a reservoir of the infection. So you don't need an infection from outside. So it's a continuous process going on. So you're having a continuous discharge. Patient is saying ki সারা বছরই জল আসে কিন্তু ভেজা ভেজা থাকে, অতটা বাইরে আসে না, because it's scanty. It's not copious because অতটা mucoid component নেই. যত mucoid component কম, তত অ্যামাউন্টটাও কম, তত নেচারটাও বেশি purulent. পেশেন্ট বলতে স্টিকি ডিসচার্জ হয়। Okay, and smell. Very good. So there is bone erosion. So there is a foul smell. And কটা বাজে রে? কটাতে ক্লাস ছিল? কটাতে ক্লাস ছিল? কটা বাজে? 1:40 এখন আসছিস? This is not an excuse. Please come on time or don't come. Please. Don't be 15-20 minutes late in a 1-hour class. So an ongoing infection is there, it's persistently there, causing a continuous discharge, and there is bone erosion. So there will be debris and foul smells because a continuous infection is there. It cannot drain. So usually it goes and forms a sac like this, cholesteatoma sac. So there is disease always present there. So like here, whenever there is an infection, there is a lot of discharge and the pus comes out. So it's drained easily. So you're not having that much of foul smell. It's not secondary ligament. So this one is causing a stagnant, is causing more smell. The intermittent and continuous amount, nature, smell. Then next. That practical, for all practical purposes, we have seen there is some smell always. It's not like it's zero. কোনো স্মেলই নেই এরকম হয় না, but it's not as much as the patient can appreciate him or herself. as compared to the atticoantral variety. ঠিক আছে, আর বল ডিসচার্জে আর কি পয়েন্ট আসবে? Color. Color, what is the significance of color? Causative organism. So mostly it will be mucopurulent, like whitish or yellowish in color in most of the cases, except for some specific infections like Pseudomonas will have a greenish discharge. To be honest, practically you'll never see, very rarely see a greenish discharge. I have seen maybe 1 or 2 cases in my entire 15 years of being in ENT. So very rarely you will see one typically classically greenish color discharge. But then again, you have to mention it in whitish or yellowish white in color. Okay. Or aggravating and relieving factor. So that is the last and one of the most important points. Like I said, when the patient is having an URTI, there is increased discharge. অনেক বেশি মুজ আসছে, সারা বছর ভালো থাকি, ঠান্ডা লাগলেই মুজ আসতে আরম্ভ করে। So this is very classically. Please don't come. It's too early for you. So whenever he or she is having a URTI, having an infection, and there is some infection in the midline, inflammation of the midline, the patient is having a discharge. So aggravating factors, what are the relieving factors? Water entry in the ear. So anything that goes through the perforation into the middle ear and starts of an infection can cause a increased discharge. So that can be water, that can be a fungal infection, that can be a secondary bacterial infection from tonsillitis or adenoids, that can be anything. Any URTI going from nose to the middle ear, anything can aggravate an infection, okay, and cause a discharge. So, but in case of atticoantral variety, there is no specific aggravating or relieving factors, because like I said, the disease is like an autonomous process going on. It is going on by itself. So we will not be able to specifically identify any aggravating or relieving factors. Okay. Our important point is associating symptoms like pain. If the patient has significant pain, please do mention it properly. Okay. Because pain means there is some degree of erosion or some degree of acute infection going on. So either the patient, most commonly is the pain which is associated. What are the other things? Itching, some basic non-specific symptoms patients may have. Okay. So this is mostly about the discharge that you need to write. These 7 points you have, it has to be there in your history, HOPI. Okay, and that too in all, try to be in patient's language as much as possible. Okay. Then comes, what is the second? Second is hearing loss. Okay. Hey, go there, ask whether you can come in or not. Have some etiquettes. Where were you? It's 1:52. So the next day onwards, try to have your lunch a little early. Jao. Nonsense. You have taken it for granted. Don't take these classes for granted. It's for your benefit. I don't have any specific interest in teaching you. It's for your benefit only. So hearing loss. What do we have? What are the important things that we need to highlight in hearing loss? Start with onset, duration. Okay. Hearing loss. Even if you have mentioned in the chief complaints, you have to repeat it in the HOPI. So how did it start? For how long it is present? What? Progression. So it is gradually progressive or it's stagnant. Okay. Then so বলছিস when you're saying that is okay. Nature, can you understand from? So nature of hearing loss ideally, so there is not, you cannot write it like nature of hearing loss, as right? What are the aggravating and the relieving factors? So like in noisy space, the patient can hear better or it can hear less, whatever it is. There is active discharge, yeah. What will happen? क्या ना होगा?
Same phase have to overlap.
Very good, very good, very good. So discharge will block the air going in through the perforation. So there will be, the phase difference will be maintained. So the patient will hear better. Maintain cold. So round window it will cover up. So we'll have the phase difference going on. Okay? That's it. Aggravating and associated features like whether there is tinnitus or not. Huh? And another thing you should mention is whether the hearing loss is fluctuating. Reservoir sign. So reservoir sign is a theory part. We'll ask questions on that. Don't write reservoir sign. But then again, fluctuating hearing loss, whether it is the patient is having a fluctuating hearing loss or it's a continuous hearing loss. So these are the two chief complaints that you have already highlighted. Then what comes? Past history आगे negative history. Never forget negative history in any long case anywhere. There is specific marks allotted for mentioning negative history. Okay, so what are the negative histories that will come? Attic, headache, headache, tinnitus, vertigo. Discharge is already there, no? Why will it come in negative discharge? And I have already mentioned in history. Fever. একটু কাছে এগিয়ে আয়, মাইক ফাইক তো নেই এখানে, ওগুলো তো যেতে হবে। Fever, vomiting, so all this comes together. Then what are the other important negative histories? What are the structures in there? Try to think what are the structures in and around the middle ear that can be affected. Ki nerve? So কি হতে পারে? Facial palsy, whether there is history of any facial paresis in the recent past or during the course of the disease. ঠিক আছে? আর কি হতে পারে? Mastoidectomy, pain behind the ear, persistent pain behind the ear. Fever you have already mentioned. Hearing loss, discharge হয়ে গেছে. So mostly this. So anything related to Meniere's disease you have to rule out because there is hearing loss. See, what are the negative histories? It's about the chief complaints, ruling out the other diseases related with the chief complaints. So discharge anyways rules out a lot of disease. And a Meniere's disease will not have discharge. But then again you are mentioning hearing loss. So you should rule out all the causes of hearing loss. Like she said, dizziness. Maybe it's a acoustic neuroma, or maybe it's a vestibular pneumonitis or labyrinthitis. Vomiting, part of those diseases. Okay, because you have mentioned hearing loss, so you need to put that in negative history. ঠিক আছে? আর কি negative history তে কি আসছে? Headache বললি, fever বললি, because these are signs of complications from chronic otitis media. Whether your patient has complications or not, whether he is having a fever like it's a sigmoid sinus thrombosis or a mastoiditis or something like that. So any infections, active infections, fever is a sign of active infection. So those things has to be put in the negative history. ঠিক আছে? এরপরে then comes past history. So what is past history actually? Past history starts or is related to the period before the start of your chief complaint. So anything before that is a past history. এরকম বলিস না past, I have seen people writing in the exam past history তে started having discharge 3 years back. No, that's not a past history. Or if the patient is having intermittent discharge, so you are writing in chief complaint Patient is having discharge from the left ear for 15 days. And then in HOPI, you have written the patient is having intermittent discharge. It started 3 years back. Now for the last 15 days, he is having discharge. So his chief complaint is 15 days only. HOPI, you are mentioning 3 years. So anything beyond 3 years is past history. বুঝতে পেরেছিস ইন্টারমিটেন্ট ডিসচার্জ হয় মানে আগের ডিসচার্জ গুলো পাস্ট হিস্ট্রি নয় পাস্ট হিস্ট্রি মানে যবে শুরু হয়েছিল তার আগেরটা ঠিক আছে ছোটবেলায় কোনো ট্রমা হিস্ট্রি আছে কিনা মেজর ঠিক আছে বা কোনো মেজর ইনফেকশন হিস্ট্রি আছে কিনা ডিউরিং বার্থ কোনো ইনফেকশন হিস্ট্রি আছে কিনা যদি বাচ্চা হয় অ্যাডাল্টে ইউজুয়ালি থাকে না তো দ্যাট ইজ পাস্ট হিস্ট্রি The past history will mention those specific or কোনো major infections হয়েছিল কিনা or negative history মধ্যে you should mention other chronic diseases like tuberculosis এগুলো তো these are very common diabetes hypertension tuberculosis so these things you will mention because these are important in evaluating the patient and following up or treatment of the patient okay so your chief complaint HOPI done so what is next past history bolli family history why it is important in chronic otitis media it's very common in families why no because of the hygiene and the place they stay in okay বাড়িতে অন্য লোকেরও হবে খুব commonly হয় so multiple members of the same family they bathe in the same pond live in the same room it's very common see this is a disease of the lower socioeconomic strata most commonly it's not like it can happen to anybody then again but it's more common in the lower socioeconomic strata so there is poor hygiene there is bathing in the same pond this is most common okay so family history other members of the family whether they have similar kind of diseases or not or then personal history addictions তাহলে pond bathing okay কোথায় চান করে it is important please mention that the patient has history of bathing in the pond for these 20 years but since childhood okay so mention that comes in personal history তাছাড়া addictions and regular diabetic surgery ওগুলো I am not going into all those details so past history হয়ে গেল now comes your examination part with general survey you all know I am not going into details surgery তে পড়িয়েছে নিশ্চয়ই general survey হ্যাঁ ওগুলো ডিসকাস করলে শেষ হবে না তো কামিং টু এক্সামিনেশন local examination okay so how do you start local examination first হচ্ছে inspection এ কি দেখবি first is mention external ear the specific side if the patient is having discharge from the right ear right external ear framework pinna or any fistula or sinus present or not swelling present or not inflammation scar mark very good scar of previous surgery also if the patient is a post-oral scar mention there is no post-oral scar okay no preauricular pits or tags or preauricular sinuses if present you write down there is a preauricular sinus present it's mostly not related to chronic otitis media but then again we should mention it because if you are planning to operate on this patient or planning to do a surgery on this patient we should address it in the same time why not okay so we mention these associated things external ear RPK discharge somebody mentioned that is very important if the patient is having a copious discharge when we are examining the external ear we would be able to see crusts or discharge collection in the external ear or the mouth of the external auditory meatus you will be able to see so mention that if you are most likely those patients are not given in the exam but mention that there is no fan discharge or no active discharge noted in the external auditory meatus or something then comes what external auditory canals after external ear or pinna external auditory canal external auditory canal কি আছে What will you use to examine the external auditory canal? Stethoscope देवे तो परीक्षा है তাহলে light and so that is important. You will be using a light source, whether it's a bull lamp or a headlight, whatever it is, and you do not use a speculum for external ears. Speculum like it was said. So it's like a tympanic membrane. External ear cannot be examined. Don't say that. Okay, so we are not using a speculum. We are using only light source, and we are pulling the tympanic membrane. What direction? Outwards, upwards, and lateral. So we have to hold the pinna, pull it in this direction. Why? To make the external auditory canal straight, because it has its natural curvature. Okay. So what are the things you may find in external auditory canal? First is obviously discharge if there is an active infection. Then wax, furuncle, stenosis. Mention stenosis. Very important. So that's it. Any external canal stenosis you should mention. The external canal is wide and patent. That rules out stenosis. Then there is no signs of any furuncle or any active infection in the external auditory canal. No discharge present in the external auditory canal. No tragal tenderness. That is important sign of ESC inflammation. So anything, any infection that involves the external ear, I know you guys are not listening. Why are you disturbing others? Why are you disturbing others? For a long time I am hearing you guys speaking. I am not telling anything because I know you don't have interest in the class. If you are not having interest, please leave. You go ahead and enjoy. I will not complain. Give your attendance, go ahead and enjoy. I don't really care about that. But let others who want to study, let them study. If you are not helping yourself, don't disrupt others, please. Just tell me, sir, I don't want to do this class, I'll leave. Leave. I don't care. I really do not care. External auditory canal, furuncle, the disease is wax. Only wax you mentioned, please. First thing will be external auditory canal wide and patent. First thing. Then any pathology or discharge present or not, that is frankly visible. If not, and what are the other things that can be present in ESC? Somebody told me in the exam. I like the answer very much. Foreign body, the একটা COM patient foreign body নিয়ে unlikely আসবে. There can be a osteoma. Okay, so this will narrow down the external auditory canal or exostosis. Okay, these are two common pathologies in external auditory canal. Okay. Keep this in mind, you don't have to write it separately, but sometimes they ask while taking Viva. What other structures can bother your examination of the external auditory canal? Okay, and if there is a frank exostosis or a frank osteoma in there, then you'll be able to write it in your exam. Otherwise, you don't have to mention specifically the exostosis ache na nahi. Don't have to mention specifically, but very frankly, that will carry some extra credits, obviously. Okay. Then comes speculum examination. Okay, speculum examination is what? What are we seeing with the speculum? We are seeing the tympanic membrane, right? So we will see a perforation. Obviously, it's the case of chronic otitis media. The perforation we will the site of perforation. That is the location of the site of perforation. That is very, 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 very important. Why? We are ruling out a atticoantral disease. Right? We are dealing with the tubotympanic disease mostly for the exams. So we are ruling out atticoantral disease. So site of perforation is very important. Which quadrant? It's a past tense of which quadrant? It's an anterior quadrant or a posterior quadrant or a anterior superior posterior pabina, most likely. It will be either anterior or a posterior, or it can be a large central perforation. All are central perforations. All of these are central perforations. Okay. It can be a large central perforation or it can be a subtotal perforation. Okay. All four quadrants are involved. Okay. So mention which all quadrants are involved. Try to draw a diagram if possible. Okay, একটা ছবি এঁকে দিবি পাশে ক্লেমার কোথায় পারফোরেশনটা কিরকম ভাবে লোকেটেড হয়ে গেল পারফোরেশনের সাইট। দেন সাইজ তো বললি, সাইজের মধ্যে কি বলবি আসছি, সাইজের মধ্যে কি বলবি? স্মল, মডারেট, লার্জ, সাবটোটাল, এই চারটে সাইজ মোস্টলি। Okay, you cannot go in and measure in millimeters, it's not possible. Somebody who writes this is surely faking. ঠিক আছে, don't write all these things. Write as a small population involving anterior, posterior quadrant, or moderate population involving anterior and posterior quadrants. Okay, cone of light is not seen. Okay, then margins of the population. Very good. Why? What is the importance of margins of a population? So that takes it to a different level altogether. When there is annual elevation, it's a marginal population. Marginal populations can very well be unsafe diseases. So don't go for that. What will happen? Irregular margins. So there, it can be a central population after a trauma. So that will give you some irregular margins. But what happens, you will never find a chronic otitis media patient with irregular margin. And it's very, very rare. Why? What happens is, already, so there is the layers of the tympanic membrane. So there will be invagination of the epithelium and it will cover up this. So the fibrous layer will not be able to grow. It will not heal. So there will be, and due to the tension in the tympanic membrane, the pars tensor has a specific tension, right? It will always come to a rounded type of perforation. The margins in most cases of chronic otitis media will be regular margins. Okay, the shape can vary. It can be a round, it can be a kidney-shaped perforation, like this. Say like this. Many patients have kidney-shaped perforation. But the margins are mostly smooth and rounded. What are the conditions that can give you irregular margins? One is trauma. Then, why is this important? I'm asking, why is this important? So there are chronic granulomatous diseases. Tuberculosis can give you irregular perforation. Syphilitic perforations. There will be multiple perforations in the tympanic membrane. So these are important. These are cross questions that may be asked. The perforation that you dekhecho, why did you mention this? What is the importance of this? In which case you can find this type of perforation. So that, what are the other types that you can say? So এইগুলো কিন্তু cross questions. Okay. So margins হয়ে গেল. Oh, first you mentioned, I forgot, that's my mistake. First you mentioned whether perforation is dry or there is active discharge. That's examination DNA at a first point. Okay. Then if it is a moist, then you should write that we mopped, the air was mopped, clean, and then examined. Like it patient দেওয়া হবে না, ঠিক আছে? But theoretical তো সবসময় তো same number of cases, adequate number of cases থাকে না. So somebody may end up having an active infection, a patient having an active infection. So mention these things. Okay. So perforation margins হয়ে গেল, perforation এর position হয়ে গেল, perforation এর size হয়ে গেল, আর very good, very good. Structure seen through the perforation. কি কি structure দেখা যাবে? আগেই malleus বলিস না, আমরা বলিস না, ফার্স্টে মিডলিয়ার মিউকোজা। Middle mucosa. Middle mucosa can be important because if there is an active infection, there will be edema of the middle mucosa, and there will be active discharge, obviously. So edema is important of the middle ear. ঠিক আছে? তারপরে ossicles. Okay? So আমাকে আজকেই আমি ওদের একটা মেয়ে এসেছিল আউটডোরে, ওকে বোঝাচ্ছিলাম। So the ossicles এ আমরা কি দেখি? When we are seeing the ossicles through the diagram, what are we seeing? So the malleus actually looks like this. Where is the handle of the malleus? So the incus is like this. There is a short process and there is a lenticular process, and it sits on the head of the stapes. Okay, so when we are having a disease, so ossicular integrity, right? That's what we are seeing, whether the ossicles are intact or not. What? Continuity কোথায় সবচেয়ে বেশি discontinuous হয়? Lenticular process. So IES joint, encurostapedial joint is the most commonly affected structure in the chronic otitis media. Okay, so see, this is the pars tensa. Right? This is the angle of the lateral pars of malleus. তো সেখান থেকে নিচে তুই পাচ্ছিস সেটা হচ্ছে pars tensa, এর উপরে pars flaccida, এটা scutum ভাগ। ঠিক আছে? So what is scutum? Can anyone tell me what is scutum? What does scutum mean? পড়েছিস scutum কথাটা পড়েছিস তো? What? That's to be very specific. What is scutum? Hidden area is the attic. What is scutum? Scutum is the outer body attic wall. So this is the EAC that comes and forms a bony outer wall of the attic and then goes to form the middle canal. So the ossicles are usually high up. মানে তুই দেখিস এটা জিনিসটা এরকম ভাবে আসে। So this is the outer bony attic wall. This is called scutum. So your epitympanum is a three-dimensional space, and scutum is the boundary, the lateral boundary of the epitympanum. Okay. So এইখানে আমি যেটা বলছি যে this is the IES joint which is most commonly eroded. So when we are seeing through a perforation here, it has to be big enough so that we can appreciate the IES joint through it. So only in moderate to large perforations or subtotal perforations mention IES joint visualized, looks intact. Or if you cannot see, do not mention. Ossicles visualized, intact. But no definite ossicular discontinuity noted. Okay? If you cannot appreciate, just like no definite ossicular discontinuity noted. That's it. Okay. Then what else? Promontory to middle mucosa দেখেছিস তার পেছনে promontory আছে. So it's not like you can appreciate the promontory specifically different. Round window you can see. Round window niche you can see. You've already seen. I'm দেখেছিস তো নিশ্চয়ই round window. এগুলো ওপিডি তে দেখবি যখন আসবি এত পারফোরেশন আসে ওপিডি তে see these things. একবার দেখলে and never forget. The thing is once you see you will never forget. Unless you see these diagrams will not help you. পরীক্ষার সময় ভুলে যাবে। একবার চোখে দেখে নে একবার you will be able to remember for the rest of your final year tenure. ঠিক আছে? তো হয়ে গেল আমাদের প্রফেশনাল এক্সামিনেশন। এরপরে আমাদের কি এক্সামিনেশন আসছে? হিয়ারিং টেস্ট। হিয়ারিং টেস্টে কি কি আসবে? তিনটে বাস, আর কিছু লাগবে না, রাইট? দিস থ্রি only. What is the importance? Why is it important for this patient? You're already seeing a perforation. The patient must have a conductive loss. So why it is important in this patient? Huh? So there can be a masked sensory loss. You are not appreciating it because you are just appreciating only the pars tensa. You are seeing the perforation. You do not know whether there is a sensory loss or not. So for that only ABC test will help. Because Rini and Weber will go with the conductive loss. Now we are considering unilateral perforation. So Rini Weber will be, Rini Weber I think you all know. Okay. So Rini Weber we all know. ABC test will have to do for sensory loss. So these three tests you should mention. Okay. Then those are investigations. These are investigations. Examination is motamoti, this is for the year. But do not forget to write examination of the nose and the well cavity oropharynx. Okay? The examiner looks for it. Look at khoje. देखिए अब ইয়ারে তো খুব সুন্দর করে ইয়ার লিখেছে, নাম করা লিখেছে কি আর লেখে? So 2 lines or 3 lines is sufficient, but should be mentioned in your sheet. Nose, no gross DNS visualized. Nasal mucosa looks healthy. No vestibular pathology. No deviated external side. Or there is a deviation, DNS to the right side. Mention that, it's okay. Oral cavity, no definite pathology noted. Oropharynx, normal. Tonsils, either has regressed or tonsils grade 1 or grade 2 in size. This much. Postpharyngeal mucosa looks healthy. That's it. But mention these two things. That brings you to the end of the examination. তারপরে summary লিখবি। Summary you can just jot up the important points and write a summary. Now the questions. The next question most of the examiners will ask, the next question will be, what is your provisional diagnosis? So you will mention, so case of a chronic otitis media with a central perforation in the anterior quadrant or posterior quadrant of the pars tensa, most likely a tubotympanic variety or a safe variety of the chronic otitis media. So this is your entire diagnosis. Oh, let's see your answer. This is common. See, during exam we have also done these things when we were 4-5 years students. So don't do that. So when we are taking on the other side of the table, we understand what mistakes students do. That's why I am telling you. Okay, try to be calm, answer the entire thing. Okay, then the examiner will ask you most commonly, what is your next plan of management? So management has 2 parts. Treatment. Investigation and treatment. So investigation and about we grossly divide into 2 parts. Investigations. No. One is, so see, how these are the tips and tricks how to write in the exam. See, or somebody when somebody asks you a question, think in your head. Exam investigation আমরা কেন করি? Either to confirm our diagnosis or to prepare the patient for the next treatment. তাই তো এছাড়া তো কোনো কারণে আমরা ইনভেস্টিগেশন করছি, এই দুটোই তো কারণ। কনফার্ম ডায়াগনোসিস করার জন্য আমি কি ইনভেস্টিগেশন করব এই পেশেন্টের? এই একটা বলছিস না, এক্সামিনেশন আন্ডার মাইক্রোস্কোপ। প্লিজ লিখিস এটা, জিজ্ঞেস করে বলিস, উইল টেক দ্য পেশেন্ট, উইল এক্সামিন আন্ডার মাইক্রোস্কোপ to see the perforation better, to appreciate the medullary structures better. Okay? Do you say this? Then, what else? Well, past culture sensitivity we normally do not do. When we do, when the patient is not responding to conventional antibiotics, we go ahead and do a past culture sensitivity. The examiner will ask you, the patient has already taken antibiotics, will you do a past culture? If not responding, then only we'll go for a past culture sensitivity, because most of our patients will have a history of prior antibiotics. Okay? And if not responding, we'll mostly consider the culture sensitivity part. Which antibiotic will help the patient to make it a dry layer. Okay? Then, audiometry, tympanometry to understand the extent of the hearing loss the patient is having. Okay, pure tone audiometry, mention pure tone audiometry. Do we do a tympanometry in perforations? We know it will be a beta wave curve. তো আমাকে মেটা দিয়ে ওপিডিতে এসেছিল, নামটা বললে ভুলে গেছি, আমাকে জিজ্ঞেস করলো যে স্যার তা আমি জানি আসবে, তাহলে ওটা পড়ি কেন আলাদা করে? ভ্যালিড কোয়েশ্চেন। ইট ইজ জাস্ট ফর দ্য ইনফরমেশন দ্যাট পারফোরেশন থাকলে বি হয়, বাট ফর প্র্যাকটিক্যাল পারপাসেস উই ডু নট ডু আ tympanometry because we know it will be a big curve. তার সঙ্গে there can be 100 pathologies, but since there is a perforated tympanic membrane, there will be no reflection, so it will be a B-type curve. There is no point doing a tympanometry in a perforated drum. Never mention tympanometry in a chronic otitis media case. ঠিক আছে? Don't utter it. Say pure tone audiometry only. Then আচ্ছা, directly will go for HRCT. Extramastoid. What is the view? Lateral, lateral, oblique view. Important. Why? Because when we do a straight lateral view, there will be overlapping of both the mastoids. We will not be able to appreciate. We will not be able to compare. একটা mastoid external উপর আর একটা overlap করে যাবে আমরা বুঝতে পারবো না that's why we do an oblique so that we can see both the mastoid cells separately ঠিক আছে HRCT scan when you are suspecting an ossicular disruption when you are suspecting an unsafe variety of otitis media when there is any complications of chronic otitis media that you can detect clinically or suspecting clinically then we go for HRCT temporal bone HRCT is not for every case
যদি অসিকুলার ডিসকান্টিনিউটা না বুঝে তাহলে তো টিম্প্যানোপ্লাস্টি করবো না মাইক্রোপ্লাস্টি করবো
so when you are doing very intelligent question actually I'll say see this you are asking because you have not done a tympanoplasty right so when we do a tympanoplasty we do a tympanotomy we see the ossicles okay we assess the mobility of the ossicular chain we see the ornamental reflex then only we put a graft in okay সেই জন্য আলাদা করে HRCT করার দরকার হয় 4B types of tympanoplasty 1 2 3 4 করে ভালো করে short columnar effect long columnar কিন্তু আছে they may ask usually they don't ask that much but when you are answering well they may ask okay some difficult questions for good students they may ask ঠিক আছে তাহলে ইনভেস্টিগেশনস হলো so what is the management our investigation and do not forget to mention if required a nasal endoscopy okay to rule out any nasal pathology or adenoids don't forget to mention a nasal endoscopy that's a part of the investigation okay so then it is treatment what is the treatment conservative and surgical or medical and surgical treatment. Medical treatment when the patient comes with an active disease we consider medical treatment. Why? Because there is an active infection going on we doing a surgery can cause complications unnecessary violating of the normal facial structures so there is no point in doing it. Okay, so we usually wait for the ear to dry we have better results it's proved আমরা এখন মাঝে মাঝে ময়েশ্চারও করি but সেগুলো কিছু patient who cannot come on a later date we have to get it done or having some complications or it's an unsafe type then we have to do a moisture on treatment এর মধ্যে antibiotics ear drops antihistamines don't forget these three এরপরে analgesic বল কি না বল is unimportant because pain is not a primary complaint in a safe type of otitis media pain is not a primary complaint so antibiotics ear drops or antibiotics topical antibiotics mentioned like that and antihistamines these three should be there okay then we wait for the ear to dry and then we go ahead and plan for a surgery ekhoniyo bollo tympanoplasty would you consider doing a mastoid surgery in this patient would you consider doing a mastoidectomy in this patient then only will do কি করি আমরা মাস্টার এক্সপ্রেশন করে এটা ক্যানাল ডাউন হয়ে যাবে তখন সব কিছু ক্যানাল ডাউন করি তাই করে সেন্ট্রাল পারফোরেশন মাস্টার আমি বলছি what is the role of master expression in central perforation mastoiditis chronic mastoiditis the patient is having discharge without any aggravating factors recurrently it dries up in only a few days it comes back okay we may consider doing a cortical mastoidectomy there may not be an ossicular erosion but that is true or there's a quasi mastoiditis in there so we are taking all the cells out we are making it a single cavity so the reservoir infection we are addressing okay so that will ensure the patient does not have a chronic infection so does not have a chronic otitis media so our surgery will be successful if you put a ear graft put a tympanoid fascia graft without this during this disorder, it will again be infected, it will again be a failure, surgical failure. Multiple times it has happened with everyone. অনেকবার হয়েছে, আমাদের সঙ্গে হয়েছে। ইউনিভার্সিটি করেছি, কিছুটা ঝুললো, থেকে গেল টিউবেশনাল পারফোরেশন, তারপরে ওখান থেকে ডিসচার্জ হচ্ছে। তারপরে রেসিডেন্সিতে খুব কমনলি হয়। Meningotomy is what is meningotomy? Meningotomy is puncturing the eardrum. They have only perforation. Why will you puncture the eardrum? ঠিক আছে?